UCSF Child and Adolescent Psychiatry portal. And it is my great pleasure to introduce our panelists today. Dr. Emily Tijani is a physician who's triple board certified in child and adolescent psychiatry, adult psychiatry, and addiction medicine. Dr. Tijani has a private practice in Marin County where she provides psychiatric evaluation, second opinion consultation, and co-occurring disorder treatment. In addition to her private practice, she is a consultant to the UCSF Youth Outpatient Substance Use Program, in which she supervises child psychiatry fellows during their clinical rotation through the clinic. And she also actively contributes to the clinic's multidisciplinary efforts to expand clinical programming and access to care for youth with substance use disorders. And Dr. Emily Asher is joining us today, who is a second-year child psychiatry fellow in the Child and Adolescent Psychiatry Fellowship and a fellow in the Public Psychiatry Fellowship at UCSF. She received her MD from UCSF and completed her psychiatry residency at Yale, where she served as chief resident in the National Center for PTSD. She's currently chief resident for quality improvement in the Child Fellowship. And she also has her master's degree in healthcare administration, public health, and public administration. Her professional interests include organizational dynamics, psychoanalysis, and healthcare systems. And with that, I will turn it over to our speakers. But just before doing that, I wanted to set some expectations around time for Q&A and really wanting to engage in some important discussion. So we really welcome questions. And when you have a question in the moment, while our speakers are talking, if you can put that into the chat, and then we'll be reviewing those questions. If it's a clarifying question around something that's just being said, and it ideally would be addressed right then and there, then we'll do our best to clarify that in the moment. But otherwise, we really want to save time for questions at the end because some of your questions may be addressed in subsequent slides. And with that, I will turn it over.
Thank you, Dr. Steinbushel.
Great. So I'm going to just get us started here with sharing my screen. Hopefully all of the technicalities will go in our favor. All right. Can you see the screen, hopefully?
Mm-hmm.
Okay. All right, so this is going to be a talk about identifying substance use disorders for youth presenting with co-occurring health issues. And we hope it's going to be informative. So the background is that if you see youth patients, you are seeing patients with co-occurring disorders. And our goal for this talk is to increase familiarity and comfort with diagnosing these co-occurring disorders. I know there's sometimes limited training about parsing these different kinds of issues apart, and hopefully by the end of this talk, you'll be much more confident going forward.
All right, I'm going to start by presenting a case for my own practice, which may be reflective of cases you've seen in your practices. I'll provide a little bit of info and we will circle back to this case at the end. I was contacted by parents of a 13-year-old girl who were requesting an urgent appointment with an addiction and adolescent psychiatrist because of the following concerns. Their daughter, who had a very easy and typical early childhood development, was very engaged in school and got along well with family. Over the past year or so, and this was in the context of the COVID pandemic, she began to not really do her schoolwork, spend a lot of time alone in her room, wanted to be with her friends and appeared to still enjoy being with friends and want to do things with them. But when at home, she was irritable, often angry toward parents, and wouldn't really talk to them much about her life anymore. She spent a lot of time on social media. Parents reported in their own words that some of the posts reflected sexual or drug references. She had had a major change in some of her interests, a newish group of friends, and her appearance and style had changed dramatically from a year and a half before. They had brought her to one therapist prior to contacting me, and she didn't really interact with the therapist, was quite angry about being there, didn't want to return. Parents met on their own with that therapist, as well as other therapists, shared the above concerns, had come to a point of having a high degree of suspicion that their daughter was using drugs and or alcohol, and that seemed to them the most reasonable explanation for why the above changes had occurred. And the therapist they met with agreed and had encouraged the parents to consider sending her to a wilderness style residential type program, and were beginning to make specific referrals. And along the way, they attempted to get a few more opinions, which is how I came to meet them. So we can just kind of keep that in mind. I think this is not an uncommon presentation seen by those of us who work with teens. Next slide, please. We're going to provide just a little bit of background and context to help orient us as we go along. As Dr. Asher mentioned, co-occurring disorders are very common in people of all ages, and in particular in youth and teenagers and young adults. Around 80% of youth who enter any sort of addiction treatment have at least one co-occurring psychiatric disorder, and about half of that 80% have 3 or more co-occurring disorders. So it's really the norm, not the exception, that psychiatric and substance use disorders co-occur together. And I actually like to think of substance use disorders as under the umbrella of psychiatric disorders, sort of a SUD psychiatric disorder or a non-SUD psychiatric disorder. Next slide, please. And just one point on semantics. Historically, we refer to these disorders as dual diagnosis, but over the past decade or so, we've shifted more toward using the terminology co-occurring disorders. That's what SAMHSA uses, and there's many reasons for that, but a couple of important ones are that the term co-occurring disorder is felt to be less stigmatizing. It kind of doesn't carry the weight or the potential negative connotation that dual diagnosis can carry, or the way it can feel for some patients. Also, we know that often it's not one SUD and one psychiatric disorder. There may be several of each. So it's a broader term that is more reflective of what we tend to see with patients. Not surprisingly, probably to those of us who work with young people, there is a developmental shift during the teenage years that kind of levels off by early adulthood, and increasing frequency of psychiatric symptoms and substance use, as well as full threshold substance use disorders in young people. So we can see here that anxiety symptoms, behavioral issues, mood disorders, and substance use disorders kind of track together, and that they peak around the late adolescent, early adulthood years. Next slide, please. And along the same lines, we, not surprisingly, can see that there are early signals or a prodrome that may be present for patients that are going to go on to develop a substance use disorder. So it's important to remember here that using drugs does not equal having a drug use disorder, an addictive disorder. There are certain criteria that have to be met, which generally involve using more frequently, using more than 1 in 10s, and having some sort of functional impairment or negative sequelae associated with the use, and not being able to stop despite the negative sequelae of using. But if we look back in the years preceding the first onset of substance use, we do see this kind of prodromal period, by which I mean there are certain symptoms or risk factors that can somewhat reliably predict any given individual's later risk of having problematic use should they begin to use drugs. This image here is from a recent paper that was published that used machine learning using prospective study information in a population of older children ages 10 to 12, and then following them for many years and looking at which symptoms at age 10 to 12 predicted a substance use disorder, a more severe or a more mild course in the late adolescent years. And you can read through at your leisure at a later point what sort of symptoms increase a person's likelihood of developing an SUD. And I think this is helpful to think about because it's a way for us to hone in on who is the high risk group, which youth may we need to screen a little more often or assess more thoroughly for substance use and for SUD. And it's hopeful in that we may be able to modify their trajectory if we can intervene early. Next slide, please. This image here is from a recent paper by George Koob, who some of you may be familiar with. He is head of the National Institute of Alcohol Abuse and Addiction. He does a lot of neuroscience research trying to help us understand the neurocircuitry and pathophysiology of addiction and the circuits that are largely involved in the development of a substance use disorder upon drug exposure are very similar, if not entirely overlapping, with the circuitry that is involved in the development and maintenance of other psychiatric disorders, such as depression, ADHD, bipolar disorder. So, deficits in prefrontal cortex or executive functioning, deficits in the reward pathway, and deficits or changes in the emotional center of the brain, the amygdala, are underlying the symptomatology or the manifestations of both of these disorders. Adolescents have certain vulnerabilities in all of these circuits, which helps kind of explain and is in line with the epidemiological evidence that adolescence is a high-risk period for both psychiatric disorders and substance use disorders. There is, of course, inter-individual variability based on genetic factors as well as experiential or environmental exposures. Next slide, please. We also have pretty good data that shows us that youth who use drugs for coping reasons, also kind of referred to as negative reinforcement, people who use drugs in order to deal with a feeling that they want to get rid of, versus youth who use for enhancement reasons to kind of feel better than well or have some fun, are at greater risk of progressing from substance use to a substance use disorder. So this is kind of in line with that paper by Koob, which was actually titled, I will get the words quite right, entirely in line with what he said, but it was along the lines of addiction as a coping response. And it was specifically referring to the COVID-19 pandemic. But there are other papers that are not specific to the pandemic where he presents evidence that supports this idea that people who use drugs to cope with painful experiences that they've had in their life, current painful experiences, or emotional or behavioral difficulties are more likely to develop addictions, to develop severe addictions, and to struggle to recover on their own without treatment. Again, a hopeful note here, which is that people who use for coping reasons actually have more robust responses to addiction treatment than people who use for enhancement reasons. So this is a population that's high risk and that can benefit from diagnosis and treatment. Next slide, please. And here, this is kind of a complicated slide. Don't get too bogged down in the neurocircuitry and neurotransmitter details, but this is again from a paper by Koob that illustrates one very important point that can get overlooked at times when working with young people or people really of any age who have co-occurring disorders, which is that at the point that a person has progressed to having an addiction, which often is many months, if not longer, into their drug use trajectory, at that point, there is something beyond just the effect of the drugs, of intoxication, that is implicated in the symptoms and the response that the patient has to drug use or drug abstinence. This is essentially sustained withdrawal. So most of us are familiar with acute withdrawal. When someone stops using drugs in those early days or weeks, there are certain physical withdrawal symptoms related to physiological tolerance or dependence. But what is actually more important when it comes to relapse, which we know is common with SUDs, is a more sustained, protracted withdrawal state that is largely emotional and behavioral, and that may not be obvious to the patient or to a family member or to a provider. This state can last for weeks or months, and this state occurs because of the way that repeated drug use changes the way the brain works. And so our bodies are always trying to maintain homeostasis. And because of the fact that drugs elicit a very large dopamine release, much beyond what any natural reward does, there is a counter response, and the brain tries to lowers the reward threshold in order to achieve reward level homeostasis. And so there's essentially an anti-reward state that is occurring during that period of sustained abstinence. So people truly do often feel worse than they did before they started using drugs. And it can be confusing, and it can be hard to understand why they're feeling worse when they stop versus, before they started or when they were using. And keeping this in mind can help us, empathize with our patients, and we can also help explain to them why it might be taking so long to feel better. Next slide, please. Shifting gears a little bit more specifically to co-occurring disorders, there's a lot of evidence that all drugs of abuse, all potentially addictive drugs, can cause or worsen a wide variety of psychiatric disorders or symptoms, at least. Often the relationship is complex, but very commonly people who present for treatment of an SUD have a history of some number of psychiatric symptoms, perhaps a diagnosis. And sometimes early in the course of using the drugs, they may feel better. Some of their symptoms may improve a little bit, but as they go on and reach the level of a addiction, the enhancement or sort of self-medicating, sometimes it's called, effect, that tends to lessen with time because tolerance develops to that. And then when people stop, they go into that anti-reward state, and they often feel worse than they did before they started using, and they may have additional psychiatric symptoms due to the withdrawal state. And again, this can make it confusing when it comes to figuring out what caused the depression, what caused the anxiety, why is it better or worse at any given point. So it really does take time to try to differentiate, is the mood symptom or anxiety symptom or psychotic symptom due to the drug use? Is it a pre-existing condition, or is it due to withdrawal? And it's actually not so important to get exactly the right answer in the moment, because often treatment will be the same regardless. Next slide, please. Here's another slide. These two, the previous one and this one, are about marijuana use specifically. We shared these because marijuana use is the drug that adolescents most often use. And we wanted to share that there's really very strong data that frequent and particularly high potency cannabis increases the risk of having psychotic symptoms, and, as the previous slide showed, depressive symptoms as well. That second connection is not as widely known. And that's important for those of us who work with youth who come in with depressive symptoms to be aware of. And even if the person feels better at first when they start using marijuana, that doesn't mean the marijuana will always help them feel better because of those brain changes that happen with chronic use. Next slide, please.
Right. Thank you for all of the background and context. What really strikes me is how miserable people are when they come to our office, and yet we have such a great potential to really do an important diagnosis and intervention. So I think that's what we're going to talk about next. So this is a very difficult task to identify substance use disorders and non-substance use psychiatric disorders. And for some of the reasons that we also suspect, like the symptoms overlap. So mania can look like meth use, and depression can look like cocaine withdrawal, and that extended, withdrawal syndrome that Dr. Tajani was talking about is often what shows up in the office. And as we were discussing before, in the prodromal state, maybe there are signs, but it's so attenuated that it's often difficult to say if, well, maybe this is just something in passing, or maybe this is a sign of something much greater that's going to get out of control without more intervention. And these both are emerging at about the same time. And in addition, there's all of the general, often chaotic environments, now the pandemic, but being in middle school and high school is no easy task for anybody. So having one disorder substantially increases the risk of developing the other disorder. So trying to differentiate the two is a key moment where you can really affect both trajectories. Outside of symptoms, patients and families may, they just may not recognize that it's a problem. Oftentimes parents will say, well, that's how teenagers are, or, this is just common. It's not a big issue. It will go away. And, or, the children may not know what is happening to them and maybe wanting to conceal, not out of, trying to confuse the picture, but because it's frightening. Likewise, parents may have other kinds of things in mind, like if my child has this condition, what does it mean for participation in services or stigma? And so there may be lots of reasons to either not know the full picture or obscure the full picture. And then, in good psychiatry fashion, all of this needs to be sorted out over many, many years, and everybody has to sort of sit with that uncertainty. And that, uncertainty makes all of us anxious, but yet it is what is, that's what's really going to help determine the diagnoses in the end. So a child comes into your office, and what would make you suspect that there are co-occurring disorders? Well, one thing is that there are very severe functional impairments. So, any psychiatric illness can cause severe impairments across domains, but if there's severity to the level where functioning is really impaired, then that's one reason that you may want to think, oh, well, there's more than just depression or more than just substance use going on. Secondly, maybe you've identified the child and as having, some condition, and you've given them some initial first line kind of medications or therapies or other services, but the symptoms don't improve. This may be another situation that there's a complexity of the presentation. One good example that we were discussing before this presentation was how often it happens that a child identified with ADHD is treated with stimulants, and yet, the hyperactivity and inattention and anxiety kinds of symptoms just don't improve. We know that stimulants are really effective. So in a lot of cases, it might not work for the child, but there might just be something else going on. Likewise, depression treated with SSRIs and therapy often is quite effective, but if there's co-occurring conditions, you just might not be able to get traction. Okay, so you have suspicion about other things that might be going on, or what do you do next? So there's two components. One is to just gather information from all the different kinds of sources that you can. One option is to screen, and there was a whole other discussion, there was another talk about screening, but the screening, just to reiterate, is about both substance use disorders and non-SUD psychiatric disorders. There are lots of different kinds of instruments that can be used, but the point is to just try and get an inventory of what might be going on by using these kinds of questionnaires. Another aspect is to try and ask multiple sources. So if you have access to teachers for other information, parents, grandparents, other people who are really involved in the child's life, those are good corroborating perspectives to get if you can. Family history is really important in terms of gathering more information, because it can often be a clue as to a particular diagnosis that might be prevalent, particularly with ADHD and bipolar disorder, which are highly genetically linked and run in families. Also, it might be helpful if a family member has a known history of some kind of illness, because they may be more familiar with those particular kinds of presenting symptoms. Once hopefully you can integrate all in the clinical picture with all of these different sources, and then you can move to, how you motivate the patient and the family to do the next step. one thing that we were discussing as we were preparing for this presentation is really focusing on patient-centered care. What are the patient's concerns, and then what are the parents' concerns? And starting with this, of course, I think is going to engage everybody in treatment, but it also gives an opportunity to investigate discrepancies. So, maybe the child says, I don't know what my parents are talking about. This isn't a problem. That can maybe bring both parties together and try and generate a discussion to reconcile those differences and point a way forward. I was mentioning the screening before, and there are lots of different instruments. The one that I think that I like is the S2BI, the screening to brief intervention. And as you can see, the question is, in the past year, 12 months, how many times have you used tobacco, alcohol, marijuana? And that has a nice point where you can stop if never, and then more questions if there are, if any of those are answered other than never. And you can pair this with CRAFT, which is another screening tool. And CRAFT stands for car, relax, alone, forget, friends, and trouble. And it asks about those different domains.
All right, so how about drug testing? This is something people often think about and may consider doing in their practice if a parent expresses concern about their child using, especially if the child denies using, or if the parent does not have strong evidence of the young person actually using. So it's fairly common. Parents come in concerned about how their child is acting or feeling, but they're not sure why. And of course, everyone wants answers because we want to be able to help these kids. Drug testing does have a place in both the evaluation and treatment of SUDs and non-substance psychiatric disorders. But often in practice, it is not used in the most effective way. So I'm just going to go over some helpful points to think about when determining whether to use a drug test in your practice with your patient. Specifically, if your practice is not addiction specific, if you're a primary care practitioner or a general psychiatrist. So first and foremost, it's important to recognize the diagnostic limits of drug tests. Drug tests are not diagnostic for an SUD in and of themselves. They can be an important part of formulating a diagnostic picture, but should not be used in isolation. And this is, because of several reasons. Some important ones are that most drugs only stay in the system. I'm going to talk about urine testing specifically here because that's what's most widely available and affordable and easy to use. Most drugs only stay in the urine for 1 to 3 days. Nicotine and marijuana, cannabis are 2 exceptions. But because of this, someone can have an SUD and test negative, especially if they know a doctor appointment is coming. They may be able to not use for a couple days. Amphetamines are largely out of the urine in around 48 hours. In addition, someone can have a positive test and not have an SUD or be anywhere near developing an SUD. Perhaps they use marijuana a couple times a year and they happen to use in the week before their well child check. They will they may not actually test positive if it was a week, but if it was a day or 2 before with that infrequent use, they may test positive. Again, doesn't equal an SUD. Also, there are a lot of drugs out there, especially these days, that aren't detected on standard screens. Things like kratom, synthetic marijuana, psychedelics, even certain stimulant drugs will not show up on a drug screen. So certainly not the be all and end all of figuring out if someone's using or what to determine based on the fact that they may have used recently. In addition, it's important to think about the ethical approaches to using urine drug testing. First and foremost, adolescents should be informed that you would like to order a drug test, and they need to consent to getting that test done. Practically, we can't really force people to provide a sample, and we shouldn't do that either. That's not ethical. We also should generally discourage parents from trying to force their kids to test at home, and we can answer questions about that at the end. Before ordering a drug test for your patient, you should think about how are you going to use the information from that test, and you should talk to the adolescent about how you're going to use that information. And to the parents, it's really best to talk openly with everyone before getting the result about what you will do with a positive or a negative result, and have some discussion about what people's concerns are. It's generally best to avoid using positive findings, so finding drugs in the urine. It's best to avoid punishing the patient because of that. Positive reinforcement works better, and we can reward teens for coming in and doing the test regardless of the result. That's a good way to get people to be adherent to the treatment or the evaluation. And we can use contingency management, which is basically positive reinforcement, to reward people for having negative results if we've previously determined that they have a substance use disorder. So if we see that their trajectory is improving, they're using less, positive reinforcement works a lot better than punishment to keep people on a positive trajectory. When you get a result, especially if it's an unexpected result, say the teen says, I've never used and there's some drug detected in the urine, it's best whenever possible to talk to the teen first alone and let them know about the result. Listen to whatever explanation they provide as to why that result may have been found. There are sometimes false positives. You can call the laboratory lab techs are very helpful with understanding, what is the likelihood of a positive, false positive or false negative. And then, you want to ask the teenager what their concern is about telling their parents about these results. And then at that point, you can go and tell the parents. You may not always tell the parents. As part of the have a plan step, you want to figure out, will you tell the parents if there is any given sort of result, and you want to all agree on the approach before you run that test. Next slide.
All right. So at this point, you have it's on your radar how much of an impact you can make by identifying and treating these disorders. Maybe you've gathered information from family, school teachers, and maybe drug testing information as well. But the key thing is when you see somebody in front of you with a core symptom, what is on the differential diagnosis and how do you differentiate? So we're going to talk about some various common presentations and how to sort it out from there. So one common presentation is hyperactivity. And is it ADHD, substance use disorder, or both? Well, to be determined, but there are clues. So, and actually beyond clues, just more information about the link between the two. Kids with untreated ADHD are more prone to substance use disorders. And then treating kids with ADHD with stimulants actually promotes engagement in substance use disorders, substance use disorder treatment. So this another more motivation to try and determine what's in front of you. So as I was talking about before, one key feature that differentiates is family history. Kids with ADHD are, if you have a child with ADHD, it's likely that one of their parents, there's 50% likelihood that one of their parents has ADHD. So that may be a clue that it leans towards that diagnosis. Likewise, oftentimes if somebody has bipolar disorder, there's usually a long period of episodes of depression and then a manic period. So if a child has never had a depressive episode, it's more likely substance use than ADHD. So what are the treatment options if you are suspecting ADHD and substance use disorder co-occurring? So this is a little bit different from treating kids with ADHD in general because of the first line treatment. So typically it would be stimulants, but there is a risk potentially of diversion, and that in particular is one reason to start with atomoxetine. Of course, atomoxetine does take more time to get effective treatment, so it takes days to weeks rather than stimulants, which can have effect right away. But that's usually considered first line in this situation. Another option or second line option is guanfacine, and guanfacine is a really good choice because it can often help kids with difficulty going to sleep. Then The last option is long-acting stimulants, and long-acting rather than short-acting because there's a smoother on-off, which is just better for the patient experience, but also there's less likelihood of abusing these medications. And then ideally there should be a contract with the patient about the specific parameters for being able to use these medications. We haven't been focusing so much on smoking, but just a note that if a child has ADHD and is smoking, bupropion might be a good choice to treat both conditions.
All right, we want to make sure to save at least 15 minutes for discussion. So I'm gonna touch upon just a few points in the next few slides, and we'll try to wrap up in the next 5 minutes. Another common presentation that we see are patients who have either manic-like symptoms, mood swings, agitation, or irritability, and it's unclear whether there is substance use involved, either causing or exacerbating these symptoms, or if it is a separate, solely psychiatric disorder. Again, similar to what Dr. Asher mentioned, knowing the family history is helpful. If there's a positive family history of a single psychiatric disorder, such as bipolar disorder, that could explain all the symptoms, we really want to dig deeper there and keep that possibility in mind. If there's no family history of bipolar or other moderate to severe mood disorders, then we need to screen or assess more in depth for other possible explanations, such as SUD. It's important to remember that substance intoxication not only can cause a manic-like picture, it can also precipitate a manic episode. And for young people who have a predisposition to bipolar disorder, using substances fairly commonly is the precipitating event that leads to that first manic episode. Not always. It can certainly happen without any substance use on board, but for people who are using drugs and are at higher risk of bipolar, because of the fact that bipolar often presents in late adolescence or early adulthood, and because substances do increase the risk of a manic disorder at baseline for people who have a history of bipolar, we often can see both disorders at the same time, leading to a more moderate to severe presentation of agitation and mood swings. Next slide. And then another common co-occurring presentation is depression or anhedonia, lack of motivation, and possibly substance use. Again, we look at the family history and the personal history. If a patient has a historical diagnosis or presentation reflective of MDD that clearly started before the substance use, say when they were in elementary school, and there's not a lot of signs that the person was using drugs in elementary school, that's uncommon. We want to be aware that there probably is some depressive disorder that will need a depressive, an MDD treatment specifically, and separate from any sort of substance use cessation or substance use disorder treatment. But we also know that drug intoxication and drug withdrawal can exacerbate underlying depressive disorders and sometimes can create a situation where the patient appears depressed, but once they stop using and get past that period of withdrawal, they may no longer feel depressed. And commonly in my practice, since depression is so common and depressive symptoms are so common, more common than things like mania or psychosis, many patients come in using drugs, disclosing their use, wanting treatment. That's why they come to me as an addiction specialist. And whether or not they had a history reflective of depression before they started using, when they stop using, when they get about a month or so of abstinence under their belt, for most people, the severity of the depressive symptoms will improve. It may not remit entirely, meaning there still may be an MDD, but a more mild MDD present. Or other times what we see is we can more clearly see other psychiatric issues that may have been, less obviously impairing than the depression and the substance use, things like social anxiety, OCD, other types of disorders, ADHD. So we by treating and thinking about both disorders at the same time, we can help patients feel better, function better. But even once one disorder is even when one disorder has been treated, we often need to kind of keep at and continue providing ongoing treatment for whatever is left or whatever emerges at the next phase. Next slide. And then psychosis, there's a couple things we can look for to kind of differentiate, but the treatment for someone who is actively psychotic will almost always involve some sort of antipsychotic medication, unless those episodes of psychosis are very brief and intermittent, a couple times a month for a few hours, they are appearing psychotic, then we may not jump to medication. And we do that whether or not we think, whether or not we know there's chronic drug use that's contributing, say methamphetamine use that's contributing, or, of course, if there is no drug use, we would use an antipsychotic. So here's where the treatment is the same, because we really do need to control the severity of the psychosis in order to keep people safe and in order to help them feel better and function better. So in these cases, it can be more clear, and it also is not required to figure out what the precipitating and sort of original diagnosis is. Next slide. We know integrated treatment is more effective. When patients get treatment for both disorders at the same time, their outcomes are better. Next slide. And just, I've outlined here kind of some general rules based on the evidence base to date about how to think about using medications in patients who have co-occurring disorders. We can think of two categories of medications for non-SUD related disorders, and then medications for SUD disorders. First of all, it's important to remember that we do have medications for addiction for certain types of addictive disorders that work. For example, opioid use disorder, buprenorphine and naltrexone are effective, much more effective than no medication. For alcohol use disorder, naltrexone or Vivitrol helps improve response and outcome. So we can use those medications even when someone has a psychiatric disorder, and largely it's very safe to do that, and using those medications will not negatively impact the psychiatric disorder. And then fairly similarly, we can use psychiatric medications to treat whatever the psychiatric symptoms or disorder is present. And largely those medications are safe to use and will not negatively affect whatever substance use or substance use disorder is present. Next slide. And this is an outline of, when to consider referral to more specialized care. The basic gist here is that if the youth is hard to engage, if you aren't getting good, reliable information, diagnosis isn't clear, that's a good reason. Also, if you're providing what the first and second line treatment is, the standard of care, and the patient is not getting better or is getting worse, that's another indicator that specialized care is probably necessary. Next slide. Dr. Asher?
Yeah. So what do you do now that if you think you have a youth in front of you who needs substance use disorder treatment? Well, one thing is that, as we've been talking about before, make sure to tell your child the plan before contacting parents. That will, not only is it just transparent, it'll foster trust in, going forward. And we touched on this earlier, but legally, parents can force the child into treatment because parents make medical decisions in this domain, but practically that's not going to really happen. So what you do is you first, a background is that the child can benefit from treatment even if they don't want it. There's a lot of discussion about among parents about, doesn't my child need to want to get better before he or she goes to treatment? And the answer is no, they can still benefit even if they don't want it. And then the other approach is to really talk to the child about, maybe your depression symptoms or other kinds of non-SUD psychiatric symptoms will get better with substance use disorder treatment. And oftentimes kids will be more willing to engage around that than substance use disorder treatment alone. So just a note about referrals. It's very difficult to find clear answers about good places to go. And I know other webinars, there's information about that. However, there is this SAMHSA Behavioral Health Treatment Finder, which can be a source. Unfortunately, the people who you can get on this resource if you sign up. So that doesn't give a good indicator of quality, but it is a place to start. I wanted to just talk about documentation and, going back to the idea of sitting with uncertainty, leaving something vague is fine, because we won't know what the disorder or disorders are until, months, years in. So saying, unspecified depression, anxiety, or other substance use related disorder is actually very helpful, because it helps first not decrease labeling and stigma, but also just for other clinicians reading this, it can help reduce, going to a diagnosis before there's a lot of clarity.
All right, I think we'll open it up for questions. I can circle back and talk about this case if we don't have a lot of questions, but we want to make sure to address whatever areas of difficulty have come up in your practice. The patient, though, did not have an SUD, and I can talk about kind of how we didn't have any SU either. No, there was no substance use. It was there were other reasons contributing to some of the problematic emotions and behavior. And through using some of the approaches we outlined here, and by sitting with uncertainty, being curious, looking for discrepancies, the patient was able to engage in treatment, come to treatment, participate in drug testing. That helped parents feel less anxious, and family work could be started, and the patient went on to have very good outcomes.
Thank you so much for that really wonderful presentation. Always learned so much. We do have a few questions. And so one of the questions is, what evidence is there around wilderness programs for helping teens with severe substance use disorder? And I know this is one that comes up with some frequency.
Yeah, so there's really no high quality evidence I'm aware of. I know wilderness programs will sometimes provide families with data from their own programs largely, and it's not like a rigorous study design. When I mentioned that the parents were thinking about sending this particular patient that I talked about in the case example, the wilderness treatment, I was in no way supporting or implying that that would be a reasonable step at that point. I actually think there's, and the evidence does show that there is potential for harm, iatrogenic harm with low quality treatment. So that's not some, wilderness programs are not part of evidence-based care. Residential level of treatment is part of evidence-based care, and there are certain practices that we want to make sure those programs are using in order to keep patients safe and provide them with care that's more likely to help them than harm them.
Thank you for that. And I know you had discussed elements of effective interventions, including residential treatment, at the last UCSF webinar. So there's a recording of that posted. We have one on our CAP website, and I'm not sure if it's posted actually to the UCSF website. If Michelle can maybe comment on that in the chat, but I can put a link to one of the recordings. And another question, can you comment about the adolescent privacy and rights to get treatment without parental knowledge?
Oh, I think I can take that one. So this is essentially, it's very, very complicated. Dr. Tajani and I were trying to sort it out before, but essentially the law favors treatment. So legally, the law favors treatment. So I think it's above age 12 and up, a child can consent to treatment for substance use disorders, even if the parents do not want that to occur. And likewise, as we were talking about before, the parents, make medical decisions for the child in most cases. But again, there's all the practicalities of actually getting the child and the parents and everybody motivated towards treatment and finding a place to go.
Yeah, and I'll also add that the state law in California is like rules on consent and confidentiality are the same for substance use disorder treatment and psychiatric treatment. But at a federal level, there are some different rules that fall under HIPAA, but that only applies, those different rules only apply to people who specifically hold themselves out to be providing addiction treatment. I'm guessing most people here today have a more general practice, a pediatric or primary care practice, or a general psychiatry practice. If that's the case, you don't need to worry about that federal law. It's called the 42, I'm blanking on the 3-letter acronym ahead of it. But so it's more complicated if you are specifically an addiction professional or if you work in an addiction treatment center. And if that's the case for any of you, we can answer those questions. But in California, there is the law encourages providers to include parents in the care of the adolescent, including disclosing certain elements of the patient's diagnosis or treatment plan, as long as it's more likely to help the patient than hurt them. So there's not a one-size-fits-all rule. You have to think about the adolescent, their family, if there is abuse or neglect or concerns that disclosure to parents may lead to harm to the young person, then you may choose not to disclose.
Great. And there's a request to show the SAMHSA slide again. So if we can pull that up. There's another question from Aaron Heath. What's going on when a teen has single use like marijuana or psychedelics and has persistent psychiatric symptoms?
So the question, I missed part of it, is it what's going on when the patient has psychedelic use or a single drug use and psychiatric symptoms?
Yes, it has a one-time use, I think, for example, pot or a psychedelic, and then has ongoing persistent psychiatric symptoms. And
that start only after that first use.
Yes, and if we didn't get that right, if Aaron Heath could chime in, you're welcome to take yourself off mute.
Okay, that is an interesting question, and one that's come up for me in my practice somewhat often the last couple of years, and it didn't really come up much before. There's an increase in psychedelic use nationally amongst all ages, in particular young people. And since psychedelics do cause such a marked shift in perceptual experience, for some people, there can be a longer period of shifts in either their sort of perceptual symptoms or experience, or their feelings about how they felt during that 8 to 10 hours of being under the influence of a psychedelic. And there isn't a lot of data or research on this yet, but myself and other colleagues, the way that we've been understanding it seems to be that there can be kind of an anxiety response to what may have happened during the period that a person was under the influence of a psychedelic, or we have seen this with marijuana as well, sort of a dissociative experience that can be quite frightening. And there is often a lot of fear or panic around having that experience again. What I've seen clinically is that if patients continue to avoid, if they avoid going back to using the psychedelic or marijuana, those symptoms usually resolve without treatment. And there are 1 or 2 studies showing that medication like antipsychotics are not helpful in those situations. But if someone continues to use psychedelics or marijuana with any frequency, the patient is likely to keep having those symptoms of either sort of altered perceptual experiences or high levels of anxiety or panic. And sometimes that can even lead to suicidal thinking because it's so unpleasant. I hope that answers the question. If it doesn't, please ask more.
I think that was the question. And I have a follow-up to that, just because I've had this with a patient. And, how do you talk about it with the patient? How do you try to help them, hopefully resolve it? Because that's obviously what they're looking for, whether or not they continue to use.
Yeah, I think it depends on where the young person is at in regard to how they make sense of what's happening. So I would first want to ask, do they think it's connected to the substance use? If they don't think there's a connection, I would want to know what their best guess estimate is as to what's going on here. I would provide some psychoeducation. There is one paper, I think it was in JAMA Psychiatry, called Cannabis depersonalization, derealization disorder. It's really the only paper out there I've seen on this topic. And so I've actually printed that out a couple times and shared that with patients who seem open to it. We don't want to shove information down patients' throats if they're not expressing an interest. But usually in this situation, patients, are so disturbed by what's happening, and they may not have a long history of substance use or psychiatric symptoms. So it can be very scary, and they're motivated to figure out what's causing this and then to stop. But there can be a tension because there may be some other different things that they like about using. Maybe it's helping with, feeling comfortable with a new peer group, or maybe there were some previous episodes of psychedelic use that were more positive, and then suddenly there was this scary kind of negative experience. So I just share with them what I know, which is when people once this has happened for someone, if they keep using, there is a pretty high likelihood that they will continue to have anxiety, panic, and some of these more negative experiences. That's just what I've seen. And I've seen a lot of teens kind of test it out a little bit. They may stay away for a month and then for any given reason, try again. And often it will be just as bad, if not worse. And after a certain number of those episodes, they'll stop. And if they need extra support with stopping, help with figuring out how to say no, how to find some other activities and friends, then we provide that support.
Yeah. And with that in mind, would you, consider any like SSRIs or other medications to help with the anxiety and or sometimes some persistent psychotic perceptual disturbances?
Yeah, it's a good question. Again, we don't really have much of an evidence base to guide us. I generally do not. I tend to be more conservative with medication. There's a number of just case reports, and what the findings are conflicting, which is that sometimes an SSRI might help a little, sometimes it could make things worse. So I try to be very cautious and use medication as a last resort. I think it's a little more clear with antipsychotics that the harm is probably greater than the benefit. Not only may it worsen, a feeling of dissociation, antipsychotics can cause, depersonalization, derealization, dissociative experience, especially if someone does not truly have like a psychotic disorder, but also there are other harms like weight gain and EPS and those sorts of things. So I actually have never used those medications in that situation. If there's a clear history of generalized anxiety or MDD that was there before the patient had the bad experience with whatever drug, then I might hold in mind the idea of starting an SSRI at some point, and depending on what the patient's baseline is, I may start it right then and there, but start very low and go very slowly and do a lot of CBT and therapy and support along the way.
Great, thank you. It looks like we are at time, but I want to thank you both, Dr. Asher, Dr. Tijani, for another wonderful presentation. Looking forward to the next one.
Thank you everyone for joining us today.
Bye-bye.
Bye.